Welcome to PEMChat. This is a peer-to-peer educational podcast about pediatric emergency medicine for the advanced practice provider. My name is Toni Dobson. I am a family and emergency nurse practitioner in Chattanooga, Tennessee, and I will be your host. Well, thank you, PEMChat listeners, for joining us today. I'm excited to be here today with Madison Matthews. She is a certified child life specialist, and I thought it'd be great to have her on the show to talk about what that is, what she does, what does that mean, kind of what the basic principles are of what they implement in the children's ED. We are very blessed and work in a facility with lots of resources, so we have child life specialists. But I know a lot of people out there don't have child life specialists, so I thought during this episode we could talk about how people who don't have these in the ER can really implement that into their care, because I have certainly done that when I worked at one of our community hospitals here in the area. So thanks for joining me today.
Happy to be here, Toni. Thanks for having me.
Awesome. Well, tell us a little bit about you.
Yeah, so I'm Madison Matthews. I'm a certified child life specialist. Like you said, I work at the Children's Hospital at Erlanger here in Chattanooga, Tennessee. I got my bachelor's of child and family studies from the University of Tennessee at Chattanooga and completed my child life practicum up in Ann Arbor, Michigan, before completing my child life internship in San Diego, California.
All right, awesome. Do you get a degree in child life, or is this like you get a degree in a certification, or?
It's a great question. A lot of universities do not offer a specific child life major. So there are specific courses that you have to take that are deemed necessary by the Association of Child Life Professionals. So although my degree is in child and family studies, I have had to meet certain courses in order to qualify to sit for the certification exam.
Okay, so a board exam like a lot of us. How did you get interested in doing this?
Yeah, so I met my first child life specialist when I was 8 years old. My twin sister, Mackenzie, is actually a medulloblastoma survivor. So I encountered my first child life specialist when I was 8 and kind of learned about the field. And then growing up, I knew I was interested in being in the hospital environment, and it just felt like a great sort of psychosocial area to go into. My dad is a nurse and my mom is a special educator, so it kind of felt like a good in-between.
That is so cool, Madison. How do I work with you and I didn't even know you were a twin. That's awesome. That's awesome. All right. Well, tell me a little bit about what child life brings to our department.
Yeah. So the Association of Child Life Professionals actually identified 5 main drivers of the child life profession. The first one being institutional savings, which I know sounds crazy because it's not what we're immediately thinking. But when preparation and procedural support are utilized by child life specialists, sedation and anesthesia can be minimized and unnecessary expenses can be eliminated. There's a study that was actually done by the Department of Pediatrics at Bay State Medical Center that published statistics regarding the reduced need for general anesthesia in a radiology setting specifically. That can include our kids from the ED that are going to CT, to MRI, to do VCUGs, all of that kind of stuff. The employment of a child life specialist reduced the need for anesthesia by 16% in children undergoing radiotherapy. And when used pre-operatively, child life specialists can reduce sedation needs from 41% to 13%. And so I think that's just an interesting statistic because that's also decreasing medical bills for families as well.
Yeah, I guess when I think about it, I think about like PTSD from procedures or the stress of the experience in the emergency department. I never really thought about it from a cost-saving point of view.
Yeah, and exactly like you said, another thing that the ACLP identifies is healthcare consumership by reducing long-term PTSD, anxiety, stress related to coming to the hospital. In the ED, my job is very focused on procedures, and I prepare children in developmentally appropriate ways for said procedure to help them understand what is going on and why. Another thing that the ACLP identifies as a driver of child life is the psychosocial outcomes, patient and family engagement, and developmental impacts. And so children who receive appropriate preparation and procedural support can show significant decreases, upwards of 59% in perceived, measured, and observed pain and distress.
Yeah, that's really interesting. I'm in a DNP program now, and we just reviewed an article that was really cool. They implemented child life. We'll talk more about it later in the podcast, but they were implementing VR with kids to see how they tolerated IV starts. And it was amazing, the difference in the outcomes they were seeing. So something really cool. Okay. Well, what would you say is your favorite part of what you do?
It's a great question. The favorite part of what I do is knowing that I'm making an impact on children and their families in the ED. A lot of my day-to-day is spent preparing and supporting children for IVs, enemas, sutures, staples, NG tubes, etc., kind of like our basic ED setup. But when I have a child who I go in the room, I introduce myself, they are demonstrating high feelings of anxiety. When I'm able to build rapport and explain it to them in a way that they can understand and they can understand why it needs to happen, and seeing them able to utilize positive coping strategies that I'm coaching them through, and seeing a kid go from highly anxious to coping well, it's very personally rewarding for me.
Yeah, I love that. What would you say is the hardest part of what you do?
The hardest part of what I do, it honestly, Toni, might be lack of understanding of my profession. A lot of people see me carrying around an iPad or passing out Legos every now and then, when in reality, I am frequently explaining to children that their sibling is dead or dying and telling people in an age-appropriate way that a brain tumor has been found in their CT scan. So in a lot of people's minds, a child life specialist has the quote-unquote fun job, when in reality, I am often presenting children and families with bad news. I present it in a way that optimizes coping and understanding.
Yeah, I'm going to share with you, I haven't told you this, but yeah, in your mind, you're like, these are people that play with kids. They get paid to come to work and play with kids. And I had an experience with you. We were going to suture a kid that was autistic, and you said to me, have we considered giving him Versed? And I said, well, yeah, but he's autistic, and, we don't usually give these autistic kids Versed. We'll probably try something like fentanyl. And you said, well, I went through the chart, and the last time he was here, he got Versed, and he seemed to do really well. Do you want to reconsider that? And I went and talked to the parent, and it did go really well. And I'll never forget that day. For me, that was a real epiphany, because I was like, this is not somebody who plays with kids. This is a medical professional. This is somebody who took the time to do a chart review and really was looking to do the best for this particular patient. And that was a real game changer for me, because I was like, oh, okay, this is not somebody who's playing at work. This is a colleague.
I appreciate you saying that, Toni.
Yeah.
It is a largely known misconception that a child life specialist job is playing. I will say that a huge component of child life is therapeutic play and medical play. They are doing a lot of that on our inpatient floors in PICU, where they're playing with dolls that have the NG tube. A lot of what we do in the ED is fast, and we're moving. And so a lot of my interactions are not actually playing, and it's more so procedural preparation. Like, you can find me at the head of the bed in a level 1 trauma talking to the child and explaining to them what's going on, and kind of consoling parents and being a real-time explanation narrator to the parents while we're intubating their child. But it is a misconception. There are even slang terms for child life specialists, which is the iPad lady. When in reality, you do see me carry an iPad, but what I'm doing is I am providing diversion and support while I coach the child through the IV. They're watching their favorite show. It's a comfort for them. It's reminding them of home. It's actually normalizing the environment.
Yeah. So you wanted to kind of talk about like sort of the theory of child life, or kind of, what the bones of this are. What does that look like?
Yeah, so there are two main theories that child life specialists, there are a variety of theories that we utilize. The two main that I find I typically use are Piaget and Erickson. It's cognitive theory. I most often utilize that information when I'm doing loss bereavement conversations regarding death and dying with the children, because depending on developmental stage, that tells me what their understanding of death is going to be and how I can explain it into a way that is optimizing their understanding.
Yeah. You mentioned kind of normalization of the hospital environment. What does that look like from your standpoint?
Yeah. So being in the ED, I am not doing a ton of normalization. I do try to incorporate it, even if it's having mom right there in your face, or doing a comfort positioning where you're sitting in mom's lap. By offering appropriate choices, I can also help with less so normalizing the environment, but helping them feel like they have a sense of control while they're in a situation that they don't have a ton.
Yeah. And is that by, offering them choices that are appropriate, or how do you do that?
Yeah. So for example, when I am doing an IV preparation support, it is very simple things like, do you want a 1, 2, 3, or do you not want to know? Do you want to watch them do the IV straw, or do you want to look at me in the iPad? Do you want to use breathy spray, or do you want to use Buzzy? Or we don't have to do any of them. It's simple things to us, but in reality, because they don't have a decision whether or not they're getting the IV, a 1, 2, 3, or a don't want to know is giving them a slight sense of control in a situation where they have none.
Right, where they can have any one of these options. Tell us a little bit about Buzzy. Some people don't have that. I've seen it in a couple places that I've worked, but many don't have it at all. What is that?
Yeah, so Buzzy is one of our pain management techniques. Buzzy is a small Buzzy looks like a bee, and really Buzzy vibrates. So you turn them on. I often see it when using for a digital block, where if you are suturing the finger, if you have the kid hold Buzzy in their hand, it is a distracting sensation. Kind of can help with that poke and warn part. We also utilize freezing spray. Pain ease spray is the technical name. And that is a very cold spray that helps take away some of the pinching feeling. And even for things like Sweet Ease, which is like sucrose, helps with babies and pain management as well. So we have all of these things in our ED that can be utilized, but you can also just get Buzzy from the store.
Yeah. Or just use your hand and provide physical distraction. My spouse was telling me on the way home today that at the dental office, when they were injecting her to distract her, the other person in the room was like rubbing her arm and talking to her. And it totally, after it was over, she was like, they distracted me. I totally missed what happened. And I was like, that was great.
Diversional conversation is also extremely effective in a situation like that. Sometimes I put the iPad away and I'm just talking to the kids about the animals that they saw at the zoo throughout their entire IV. And that is also providing procedural support.
Yeah, yeah. Let's talk about the one voice. Is it the one voice theory?
It is the one voice theory.
Okay.
Yeah, so it's a theory that was developed by a child life specialist over 30 years ago that essentially says that a child should be hearing one voice during a procedure, like one actual person talking. And a tangible example of that is, imagine you are a 6-year-old child. You're in the hospital. There are 4 strangers talking at you, telling you what to do, coaching you, etc. Hold your arm this way, pump your fist, etc. That is extremely overstimulating to some children. By using a one-voice approach, it lowers the stimulation in the room and it helps the child focus on, typically, I am the one voice in our EB during procedures. It allows you as the provider and as the nurse to focus on what you are doing while I have the kid engaged with me. I'm coaching them. I'm encouraging them. I'm praising them on their bravery. And you're doing a great job holding your body still. Because I have often typically met the child beforehand during a preparation, I also have a little bit of rapport building. Whereas I'm going into the room with the nurses to do the IV, sometimes the nurse coming in hasn't met them yet. And so because they have met me and I deem myself as a quote unquote safe person, me being the one voice is effective because they are able to focus on me while you are doing the sutures.
Yeah. Do you prep the parents for that?
So parents can also be one voice. You can be the one voice. Anyone can do the actual talking. I often find that when a patient is escalated, a parent also is demonstrating some feelings of anxiety. And so by coming in and being that firm, calm, therapeutic voice, the parents normally kind of go hand in hand with me, or I will take turns being the one voice with the parent.
Yeah, my experience is a little bit all over the place. Like, I feel like when you guys come in and do that, it works so well. And I just try to be quiet. But then there are other times where the parents just like, no, do this, watch this. It's just, and you're like,
yes,
I'm confused. And I'm not the kid that is getting their face sewed up. It's frustrating. So yeah, I often get to I miss, the prep unless you're doing it right there when I start. And so I don't get to see all these things that you can.
And most people don't see the actual preparation part. Even the nurses don't see when I'm prepping the kid for the IV. They see me providing the support when we go in.
Yeah.
But in reality, I've already spent a few minutes with that child and family where I'm prepping the kid and also the parents as well, so that they are hearing the verbiage that I'm using and can kind of repeat that back to the child.
So let's talk about, like, if you're going to sew, I'm going to sew a kid's face or whatever. Walk us through what a prep looks like. What do you typically say?
Sure.
What do you do?
So I always introduce myself as Madison. I'm one of the child life specialists. My job at the hospital is just talking, kind of about what to expect. And I ask the child, do you know what the plan is to help the cut on your forehead today? A lot of times, sometimes they say, yes, it's stitches. Sometimes they say, no. I say, okay. So the plan is to do something called stitches, but I like to call them string band-aids because that's kind of what they are. And they're going to help where the cut on your forehead is close together so that it can heal. And we, of course, use LET at our hospital, which is like a topical numbing. And I say, did the nurses put some medicine on your forehead? And they're like, yeah. I'm like, did they tell you what it's doing? Sometimes they say yes, sometimes they say no. I say the medicine on your forehead is helping where your cut is feel like it's sleeping. So when it's time to do the string band-aids, you will feel a lot of touching and pushing, and some kids even tell me that it tickles. But because we have the medicine on our forehead, that helps take away any pinches or pokes. And when I'm doing a suture prep, I also bring example sutures and hemostats with me. And I say, do you want to see what the string band-aids look like? And I pull it out and I say, oh, it kind of looks like a kitty whisker. What do you think it looks like? And then I show them the hemostats and I say, what do you think these look like? And they say scissors. And I'm like, well, check this out. And I take the string band-aid out and I put my finger in the hemostat and I say, look, these scissors are not sharp. Their job is just holding on to the string band-aids. And then I also talk to the kid about what their job is. Normally their jobs, what I often say, the first job is to hold your body as still as you can, because that will help us get the string band-aids into the right spot. And your second job is this. And then I take a big, deep breath in front of them and I say, can you do that too? And then we practice taking big, deep breaths. I also explain to them, when it's time, we will probably have you laying down. We might have your head on this other side of the bed and we'll pump you up really tall. The first thing we'll do is take off that band-aid and do some cleaning with water. And then you'll feel some of that touching while we do the string band-aids. I also develop a coping plan with the patient. I say, I have an iPad. If you want to watch something while we do the string band-aids, you can. And so oftentimes we kids light up when they hear that. And as you know, I literally hold the iPad up straight up in the air so that they can still watch Bluey while you're sewing the forehead. When we're actually doing it, I'm talking through reminders as we go. Okay, you're going to feel the cold water on your head. This is making sure the cut is clean. And you're going to feel the touching and pushing part next. And then even after you do the drive through and you're pulling the suture through, I say, here comes the tickle part. Because a lot of times they feel that tickling strain. And that can be scary for them because they don't know what's touching them. Mm-hmm. And so I'm providing encouragement. I'm repeating the steps. I'm saying you're doing such a great job holding your body still. We've got mom and dad right here with you. Sometimes I engage them in that diversional conversation that we were talking about and all of that kind of stuff. I oftentimes ask them questions. Most of the time, the questions after the fact are, is it going to hurt? And so what I do is I can do a teach back question where I say, are your string band-aids going to feel like pinching and poking? And then I say, no. Is it going to feel like touching, pushing, and tickling? And then they remember that that's what I said and say, yes. And so that helps me know that they actually demonstrated some understanding that it is going to feel like touching, pushing, and tickling and less like pinching and poking.
Yeah. And it's, so much of what kids have anxiety about is just not knowing. They don't know what's going to happen. Mm-hmm. I try to always say, hey, we're not going to do anything without telling you first. Yes. But you guys do such a better job kind of laying out that prep on the front end, which is awesome. Okay. So you mentioned brain tumor diagnosis. That's certainly something we don't do every day, but we do our fair share. What does talking to a kid about that look like? Yeah, well, it's hard, first of all. It's typically a very emotional moment because if they have a newly found tumor in the ED, our provider is going in and talking to the parents. There is a specific patient that comes to mind who I was a part of the conversation to inform her of what was going on. The doctor stepped out with mom first to share with her. And then we came back in and I said, Mom, part of what I can do at the hospital is help facilitate a conversation with the patient to help her understand why she's not going home. And so specifically with the brain tumor, we're doing obviously a variety of imaging. I do a lot of questions where I ask them, why are you at the hospital? For this patient, well, the eye doctor said I needed to come here. And I'm like, okay, do you know why the eye doctor needed to come here? Told you that you needed to come here. And the patient said they saw something behind my eyes. So then I kind of talk about the MRI. This patient was going for an MRI. She was 8 years old. I was actually able to coach her to be able to sit for the full brain MRI without needing anesthesia.
So then after she came back from that, we got the results. The provider spoke with the parent outside of the room. Then we all kind of reconvened in the room with the patient. And I explained that when the doctors were looking at the pictures that we took of your brain, the doctors found something that is not supposed to be there. And the doctors think that what they found in the pictures is what's making you nauseous. It's what's making your eyes hurt. And what we need to do is take some more pictures so that we can come up with a plan to help your body start feeling better. So sometimes they have questions, what did they find in the pictures? I can explain that the fancy word is called a tumor or a mass. But in reality, I try to simplify that language down to an appropriate developmental level where they are able to verbalize back to me that there is something that they found in the pictures in their brain that is not supposed to be there and it's making their body feel sick.
Mm-hmm. Yeah, I love that. So when we have traumas, I'm not often involved, so I don't get to see what your role looks like there. What does it look like if you're going to kind of help with a family in a trauma situation?
So it definitely depends on the trauma situation. Honestly, if they're intubated, sedated, paralyzed, I'm not speaking with the patient. In a situation like that, I sort of head on family, where I will grab the mom and dad. Even if this is a level 1 trauma, the entire hospital is in this room, I grab mom and dad and I say, follow me, I'm going to show you where we're going to stand. And I will elbow my way in there with parents. In a situation like that, I'm doing real-time narration. I am explaining that this is Toni, the NP, this is our respiratory therapist, this is Dr. whoever, they are in charge of what's happening right now. I'm basically explaining to them what is happening, being a medical interpreter, really. If the patient is awake and alert, you can typically find me at the head of the bed. I am speaking in a low, quiet, calm tone to the patient. I'm explaining who is touching them, what is happening, what's going to be happening next. I can even do my IV prep in 30 seconds before that poke comes. I even have helped facilitate where they roll the patient to check C-spine in the back. I need you to tell me yes or no if it's hurting you. And so just providing the same real-time preparation, but to the patient, even in the midst of a very chaotic environment. I try to implement the one voice theory there as well. I have had residents ask the patient questions through me because I have built the rapport. I'm right there in their face talking to them. I'm calm, I'm quiet, I'm staying consistent. Where the resident says, okay, Madison, I need you to tell them to move their legs. And so I whisper that to the patient and they do it. So it looks different depending on what the situation is. Obviously, if we are coding a patient, if we're actively doing compressions, I will also stand in the bay with parents, explaining what's happening and why, sort of regardless of what's going on.
Yeah. So I just learned that, if we have a death in the ER, you're kind of an integral part of that, particularly when there's family with maybe other children involved. What does a conversation look like, in that regard?
Sure. So in the ED, if a death happened, it typically is a traumatic death in the bay, or it's like a SID baby that comes in the middle of the night. A large part of my job is facilitating bereavement conversations, whether that is with parents, with siblings. I can even be consulted to the adult side to talk to the children of adult patients there. In the ED, a lot of times because we are having traumatic death and the medical examiner has to come in, I'm unable to do something called memory making. But if I am consulted up to the PICU or other areas of the hospital, Child Life also offers memory making or legacy building, where we can do handprints with the family. We take a lock of hair. We do a heartbeat in a jar. We can even emboss handprints. Mainly what I do in regard to death is facilitate conversations with siblings. So in our ED before, if a child has passed in our trauma bay, I facilitate a conversation with the sibling and the parent to explain what has happened. And that's a really hard thing to do. And we don't typically think of that when we think of child life, but it is an integral part of our job. In regard to facilitating a bereavement conversation, I meet with the parent first and I say, do you know what the child knows? And I just kind of take it from there. Sometimes if it's in the ED, of course, it's often unexpected. And that is a very emotional roller coaster. I think it's important to, if we're coding a child in the bay and then we stop and the child has passed, I allow that moment to happen with the family. I think that that is a sound of a parent wailing is something that nobody ever forgets. And I think it is of my personal and professional opinion that you have to just let that moment happen.
Agreed. Yeah.
Yeah.
It's hard to hear every single time it happens, but it's just a part of our grieving process for sure. And are the kids, have you seen like families bringing everybody in at the same time? I haven't seen a lot of that.
Yeah. So I'll think typically when I'm consulted to do a loss and bereavement conversation, it is up in our PICU after hours because child life up on the floor did like a normal 9 to 5. I work into midnight. So anytime there is a death in our children's hospital after normal business hours, it is myself or our other ED specialist, Taylor. When I am presenting a child with this conversation, I ask them why they're here to see their sibling. Sometimes they do, sometimes they don't. Sometimes the parent wants to take the lead on the conversation and explain that the sibling is dying. I welcome that and I kind of support. But it's important to say that blank's body is so sick or so hurt that it's not working anymore. And no matter what the doctors were doing and what the nurses were doing, their body was not getting better. And I say, do you know what happens when our body is not working anymore? Sometimes they say yes, sometimes they say no. And I have to explain that when our bodies are not working anymore, no matter what the doctors and nurses are doing, our bodies die. And then I have to ask the child, do you know what it means when somebody dies? Sometimes they have had a pet that dies. Sometimes they've had a grandparent that dies. That it can be helpful because they have a previous experience. But I often find myself having to explain that when our bodies die, that means we don't get to see the person anymore. And we don't get to touch the person anymore or talk to them. But I also heavily emphasize that there is nothing that anybody has done wrong to cause this. Because depending on developmental stage, a child will think that they have done something wrong, that this is a punishment. I also stress that sometimes grown-ups don't even know why things like this happen.
Yeah, that's hard. How do you keep you healthy when you're dealing with a lot of this sort of sad part of your job?
Honestly, I cry out sometimes. After I watch a lot of people find out that their family member is dead or dying. And that is a very hard thing to observe. It's not normal to watch that or to work with people who have passed while I'm doing memory making. So I find it important to allow myself to feel it and to feel emotional. My partner also is in the medical field, and so that is very helpful because being able to talk about it with somebody who gets it is very beneficial to me as well.
Yeah. Have any good hobbies?
I'm into plants.
Yeah, me too. Awesome.
Yeah.
If I could spin the camera around, you'd see the 50 houseplants that are on my desk here.
Over here
I see
as
them
well.
behind you. Yeah. All right. Well, I wanted to touch a little bit on like emerging technologies in child life. So we'll kind of switch over to a happier topic.
Yeah.
What do you know about things that are kind of new in the field?
Yeah, so like you mentioned earlier, the VR goggles are something that we have in CHED. Sometimes we're not using it on an everyday basis. I think it takes a special patient to be able to, because some kids, of course, want to watch the sutures happen or the IV happening.
Wait a minute, but I didn't know this, and I work in the CHED. How is it?
So we do have a pair of goggles, and it can be very beneficial. I find that it typically works better on an older patient who has already verbalized understanding of what's going on and why, and then they are able to just fully go into that distraction with the VR goggle. Up on the floor, we have like gaming systems. We have a whole playroom. We obviously use iPads a lot as well. So a kid can be playing a game while you are doing the IV. And so it is very helpful in the diversion support side.
Yeah, I want to use the VR.
Yeah.
Next time I have to put a finger back together, we need to do that. That's awesome. Okay, well, I think kind of the most valuable part of this entire podcast is let's talk about how people in outside community facilities that don't have you there to do this for us, how can we like implement some of these techniques into what we're doing when we take care of kids to make it easier for them?
Sure. So it seems simple, but to physically get on the patient's level as a provider it does wonders. If you're going into a room, it's already a scary environment. You're towering over this child sitting in the bed. If you can sit on the stool, if you can even kneel down or sit on the bed with the patient, that is kind of putting everybody on a level playing field. Something else that you can do is meet the patient where they're at emotionally. If you walk into the room and the kid's bouncing off the wall, you meet them at that level with enthusiasm. But when you walk in and the kid is demonstrating high feelings of anxiety, they're hiding in the corner, that's when you can kind of mellow out yourself. So kind of matching the emotional level that you're getting from the child and family helps deem you as a safe person as well. What you can also do is let the child know what you're doing and simplify your medical terms. It seems silly sometimes to ask, like, do you want the 1, 2, 3, or do you not want to know? But it really does give them a small sense of control in a situation where they have none. If you're doing something and a child is escalated, it is okay to validate those feelings. You can reassure them that what you are doing, you're doing it to help their body start feeling better. When we're doing something like a digital block, that's a big poke and warm sensation. But what you can remind them is that this is going to help your finger feel like it's sleeping. So when it's time to do the string band-aids, it will just feel like some touching. So letting the patient know what you're doing, and you can even implement one voice. If you don't have a child life specialist, you as the provider can be the one voice, or the parent can as well, but validating the child's feelings even if they're escalated, and kind of praising things that you're identifying. If the child is doing a good job holding their arm still, you can say, you're doing a great job holding your arm still, or thank you for telling us how you're feeling, or you're being very brave and you're safe and mom and dad are right here with us.
Yeah. For me, one of the most challenging things is when you go in and say the LET doesn't work. And I've kind of prepped them for, I put this LET on and it's going to make your skin sleepy and I'm going to come in and it's not going to hurt. And then it hurts and I have to do an injection.
Yes.
Right. And so the injection hurts. I typically say, it's going to be spicy for a few seconds and then it's going to go to sleep. But I've lost them at that point, right? Like I went from this isn't going to hurt, I'm not going to have to do anything, to now I've had to inject your skin. How do I win them back? How do I get them back?
Yes, that's a great question. A lot of times, if I know it's in an iffy spot, if we're doing the LET on a hand, and I'm like, oh, I'm not sure if this is really going to work, I can oftentimes in the prep say, we have extra sleepy medicine that we can give if it feels like pinching and poking. So if it feels like pinching and poking, we want you to tell us, and we will give you the extra medicine. In a situation like that, Toni, that you're explaining, when it's a game time, okay, we're going to have to inject, the thing that I say to the child is, we don't want it to feel like pinching and poking. You're telling us it's feeling like pinching and poking, so we are going to give you extra medicine. And this medicine is different than the kind you had on the Band-Aid. This medicine, a lot of kids tell me it feels like a poke and then really warm. And after the poke and really warm, it will feel like it is sleeping.
Yeah, yeah. And that's great advice. What about for me as a provider, I came from OB. So I certainly think it's important to not waive tools. Upstairs, it was, speculums and KY and all that stuff. I always tried to keep that out of the patient's view before we were doing exams, just because I appreciate that when I'm a patient. Do you feel like that's important for kids?
It is, especially if the patient is interested. What you can do is ask them first, do you want to see fill in the blank before we use it? Sometimes they say no. Then okay, they don't want to know. But we have a lot of example medical equipment that we utilize in our prep. I have an example NG. I have an example enema thing. I have we carry example IV catheters during my IV prep so that I can explain that really it's a soft medicine straw.
Yeah.
So you can always ask them, do you want to see it or not?
Yeah. And I always just try to kind of keep it covered next to them, and then it's not all.
You can also position yourself in a way that they're not going to see you driving with the needle. And that's where, if you're doing the forehead lock, you stand behind them, and so that they can look at me and mom and my iPad while you're out of view.
Yeah, makes such a big difference. All right. Any last little pearls or tidbits to share with us?
Yeah, I think that just raising awareness is what child life is can be very helpful for our profession, because a lot of people have misconceptions or think we just come to work to play, when really we are helping children and families deal with hospitalization in general, with a new diagnosis, with a procedure, and even death and dying. And so utilizing child life appropriately can be so beneficial to long-term coping for a child and their family. And I think it's just important to kind of share the information, because a lot of people don't know what a child life specialist is unless they work in a children's hospital or family members or friends with them.
Yeah. I think it's great. We're so happy that we have you and Taylor both. You're both awesome. All right. Well, thank you so much for being here today. I appreciate your time.
Yeah, thanks for having me, Toni.
All right. Thanks again, PemChat listeners, for being here with us today to talk to Madison Matthews about child life specialists, what they do, and how we can maybe implement some of these skills into our own patient care experiences so we can make it just a little better for our pediatric patients. So thanks so much for being here with me, Madison. Now, join us next month when I'm going to be here with two people, June Bryant and Cheryl Faber. They are from the Dysautonomia Project, and they're going to be talking to us about what is dysautonomia. What does that mean? How do we treat it? How do we spot it? How do we diagnose it? So join us next time when we will be talking about all things dysautonomia. I'll see you then. Any opinions expressed on today's podcast are solely those of the speaker and do not reflect the opinions or policies of any employer or hospital system. In many states, advanced practice providers work collaboratively with physicians. One should always be careful to consult with your physician leader when it's appropriate. This podcast was designed for medical education purposes only. Its speakers have made every effort to provide the most current and evidence-based information. However, that should never replace one's own effort to validate current evidence-based practice before implementing a plan of care. Any pathway or algorithm that we may have discussed may not reflect those of your healthcare system. Please be aware that these may change based on your geographic location or current employer site. This podcast was not designed in any way to provide medical advice or treatment plans for patients and their families. If you have a medical concern or an emergency, please be seen by a local medical provider or call 911 for assistance.